Tuesday afternoon. A 28-year-old woman walks into your GP clinic. Lupus, joint pain, rash, and now her urine dipstick shows 3+ protein and blood. Her creatinine is creeping up. She's been on hydroxychloroquine alone. You know this is lupus nephritis, and you know the stakes. Half of lupus patients develop kidney involvement, and lupus nephritis remains one of the leading causes of morbidity and mortality in these patients.
And the management has been stuck for decades. Mycophenolate plus steroids, or cyclophosphamide for induction. Then maintenance with mycophenolate or azathioprine. We've added belimumab and voclosporin recently, but complete renal response rates still hover around 30 to 40%. That leaves the majority of patients with persistent proteinuria, progressive kidney damage, and cumulative steroid toxicity.
Good morning. It's Tuesday, August the 5th. 4 stories today, and the first one offers a genuine new option for exactly that patient. Story 1. Obinutuzumab for active lupus nephritis. Published August 3rd in the New England Journal of Medicine.
Obinutuzumab is a type 2 anti-CD20 monoclonal antibody. It's already approved for CLL and follicular lymphoma. The mechanistic rationale is straightforward. Deplete B cells more completely than rituximab, and you reduce the autoantibody production that drives lupus nephritis. Rituximab showed promise in lupus nephritis, but failed its phase 3 endpoints. The question is whether a more potent B cell depleter does better.
This was a randomized, double-blind, placebo-controlled trial. 271 patients with biopsy-proven active lupus nephritis, class 3, 4, or 5, all received standard background therapy with mycophenolate plus prednisone. Then they were randomized to add intravenous obinutuzumab or placebo. The primary endpoint was complete renal response at week 76.
And the result? 46% of the obinutuzumab group achieved complete renal response, compared to 33% of placebo. A 13 percentage point absolute difference. The odds ratio was 2.2. This crossed the pre-specified threshold for statistical significance.
Let me translate what complete renal response means. It's not just some proteinuria reduction. It's a composite of proteinuria below 0.5 grams per day, estimated GFR preservation, and no rescue therapy. This is the endpoint nephrologists care about. It predicts long-term kidney survival.
And 13 percentage points on top of standard therapy is meaningful. If you treat 8 patients with obinutuzumab instead of placebo, 1 additional patient achieves complete renal remission. That's a number needed to treat of 8. For an autoimmune kidney disease where options are limited, that's clinically relevant.
The safety profile is worth examining. Obinutuzumab had higher rates of serious adverse events, driven mainly by infections. Infusion reactions were more common, as expected with any monoclonal antibody. There were no unexpected safety signals. This is an immunosuppressive drug added to other immunosuppressive drugs, so infection risk is inherent.
But here's the critical context. Obinutuzumab is not yet TGA approved or PBS listed for lupus nephritis. It joins belimumab and voclosporin as potential add-on therapies. Belimumab was approved based on a 12% absolute improvement. Voclosporin showed a similar magnitude. So obinutuzumab sits squarely in the same efficacy range. The real question for rheumatologists and nephrologists will be sequencing. Which agent first? And can we combine them?
For the GP, the practical message is this. When your lupus patient has proteinuria, refer early. The treatment landscape is expanding. Complete renal response is now achievable in nearly half of patients with the right combination. And steroid sparing is the direction of travel. Every additional drug that gets us off long-term prednisone matters.
The limitation I want to flag. This trial excluded patients with very severe disease or recent 4-cyclophosphamide. The generalizability to the sickest patients is uncertain. And the follow-up is 76 weeks. Lupus nephritis plays out over decades. We need long-term renal survival data.
Story 2. And this one takes us into territory that's generating enormous interest and equally enormous caution. GH001. Inhaled mebufotenin, also known as 5-MeO-DMT, for treatment-resistant depression. Published in JAMA Psychiatry.
Let me be precise about what this compound is. 5-MeO-DMT is a naturally occurring psychedelic. It's found in the Sonoran desert toad secretions, but the pharmaceutical version is synthetic. It's a short-acting serotonin 5-HT2A agonist. Unlike psilocybin, which produces a 4 to 6 hour experience, 5-MeO-DMT produces an intense experience lasting 20 to 30 minutes. The inhaled formulation means peak plasma levels in minutes.
This was a phase 2b randomized trial. 81 adults with treatment-resistant depression, meaning they'd failed at least 2 antidepressant treatments. They were randomized to one of 4 GH001 dose regimens or placebo. The primary endpoint was remission at day 8, measured by the Montgomery-Åsberg Depression Rating Scale.
And the result was striking. 57.5% of the GH001 group achieved remission at day 8. 0% of the placebo group. 0. An effect size of 2.0. For context, a typical antidepressant effect size is around 0.3. This is nearly 7 times that magnitude.
That's a one-day intervention producing remission in over half of treatment-resistant patients within a week. If replicated, that would be transformative. These are patients who've failed multiple treatments. A single-day psychedelic session producing remission in more than half of them is unprecedented.
But the limitations are significant, and I need to be transparent about them. First, blinding. Anyone who inhales 5-MeO-DMT knows they've taken it. The experience is unmistakable. So expectancy effects could inflate the results. Second, the follow-up is only 7 days of controlled observation. We have no idea about durability beyond a week. Third, this is phase 2b, 81 patients. Phase 3 trials are ongoing.
There's also a safety consideration specific to 5-MeO-DMT. The experience is intense. Cardiovascular effects include transient hypertension and tachycardia. There are case reports of adverse events when used outside clinical settings. This is not a compound for unsupervised use. The trial protocol included medical screening, psychological preparation, and trained session monitors.
And I'd add a broader caution. The psychedelic therapy field has had a reckoning recently. The episode trial of psilocybin was negative on its primary endpoint. Questions about functional unblinding inflating effect sizes are now central to the debate. The GH001 results are impressive, but they need phase 3 replication with active comparators, not just placebo, before we can trust the effect size.
For now, the clinical message is measured optimism. This is not available in practice. It's not TGA approved. But when patients ask about psychedelic therapy, and they will increasingly, you can say the evidence is genuinely promising but still experimental. The phase 3 program will determine whether this enters clinical practice. Story 3. And this one is for the stroke physicians and anyone involved in acute stroke care. The Choice 2 trial. Adjunctive intra-arterial alteplase after successful mechanical thrombectomy. Published in JAMA.
Here's the scenario. A patient has a large vessel occlusion stroke. They undergo thrombectomy. The clot is removed. TISI 3 reperfusion. The artery looks open on angiography. The question is, do you stop there, or do you deliver alteplase directly into the microvasculature to dissolve residual microthrombi? The theory is that distal microvascular obstruction persists even after macrovascular reperfusion, and dissolving it could improve tissue salvage.
Choice 2 randomized 440 patients across 14 Spanish stroke centers. All had successful reperfusion, defined as TG2C or 3, after thrombectomy. They received either intra-arterial alteplase or sham, delivered through the microcatheter at the occlusion site. The primary outcome was excellent functional outcome at 90 days, defined as modified Rankin scale 0 to 1.
And the efficacy signal was positive. 57.5% of the alteplase group achieved excellent outcome, compared to 42.5% of the sham group. A 15 percentage point absolute difference. That's a number needed to treat of about 7. For a stroke intervention, that's substantial.
But there's a catch. And it's a serious one. 90-day mortality was higher in the alteplase group. 12.1% versus 6.4%. That's a statistically significant difference. P equals 0.03. More deaths in the treatment arm.
And that mortality signal is the entire story. You cannot ignore a doubling of mortality in a stroke trial, even with a promising efficacy endpoint. The investigators acknowledge this. They note that the mortality difference was driven primarily by the large core subgroup, and that the deaths were heterogeneous in cause, not all hemorrhagic. But the signal is there.
This is why Choice 2 is promising but unresolved. If the efficacy signal is real, intra-arterial alteplase after thrombectomy could improve outcomes for the patients who don't fully recover despite macrovascular reperfusion. But the mortality signal demands explanation. Phase 3 trials are needed to determine whether the benefit-risk balance is favorable.
For the rural GP, this is less directly applicable because thrombectomy happens at comprehensive stroke centers. But it matters for referral decisions and for understanding the evolving stroke intervention landscape. The message is that mechanical thrombectomy may not be the end of the intervention. Adjunctive pharmacotherapy delivered intra-arterially is an active area of research with unresolved questions.
Story 4. And this one is directly relevant to every anaesthetist and every GP who manages patients on GLP-1 receptor agonists. Updated ANZCA perioperative guidance for GLP-1 and GIP receptor agonists.
This has been a moving target. The original concern was pulmonary aspiration under general anesthesia. GLP-1 agonists delay gastric emptying, so the theoretical risk is that patients arrive in theater with a full stomach despite standard fasting. The American Society of Anesthesiologists initially recommended holding GLP-1 agonists before surgery. Then data emerged showing that simply holding them didn't reliably empty the stomach, and patients were losing glycemic control.
The updated ANZCA guidance, developed jointly with JESA, the Australian Diabetes Society, and NACOS, takes a clear position. Do not stop GLP-1 or GIP receptor agonists before procedures. Instead, use a 24-hour clear fluid diet before the procedure and proceed. This is consistent with the latest US and UK guidance.
Let me unpack the reasoning. When you stop a GLP-1 agonist, gastric emptying recovers within about a week. But blood glucose deteriorates immediately. For a patient with a HbA1c of 8.5 on semaglutide, holding it for a week preoperatively means operating on someone with unstable glucose. The aspiration risk from delayed gastric emptying is theoretical and has not been borne out in observational data. The metabolic risk from stopping is real and immediate.
The guidance includes a decision aid flowchart and a patient information sheet. The practical protocol is straightforward. For elective procedures, continue the GLP-1 or GIP agonist at the usual dose. Prescribe 24 hours of clear fluids before the procedure. On the day, assess as per your usual fasting protocol. If there's clinical concern about delayed gastric emptying, use ultrasound assessment or consider rapid sequence induction.
And for the GP who refers patients for procedures, this matters because your patients will ask, should I stop my Ozempic before my colonoscopy? The answer per NCA is no. Continue it. Just follow clear fluid diet instructions. This simplifies preoperative management enormously and prevents the glycemic deterioration we used to cause by holding these medications.
There's one important nuance. This guidance applies to standard dose stable patients. For newly initiated GLP-1 agonists, within the first 4 weeks, or after a dose escalation, gastric emptying effects are more pronounced. In those cases, individualized assessment is appropriate.
Quick hits before we wrap up.
First, PBS September brand changes. From September 1st, clopidogrel brands and GTN patches are being removed. Transition your patients to remaining generics. Check the PBS schedule for the exact brands affected.
Second, the RACGP has released the 3rd edition of its osteoporosis guideline. First update since 2017. It incorporates the new osteoanabolic therapies, abaloprotide and romosozumab. With 6 million Australians affected by osteoporosis or osteopenia, this is essential reading for every GP.
That's the show. 4 stories today. Obinutuzumab expands lupus nephritis options, with a 13% absolute improvement in complete renal response. Inhaled 5-MeO-DMT shows a remarkable but unconfirmed signal in treatment-resistant depression. Intra-arterial alteplase after thrombectomy improves functional outcomes but carries an unresolved mortality signal. And ANZCA says continue GLP-1 agonists perioperatively with a clear fluid diet.
Stay sharp. We'll see you tomorrow morning.